So my name's Reka, I'm one of the F2s here, and this was the research project that I've been undertaking over the last 4 months, looking at the north-south divide and cardiovascular risk factor trends over this 7-year period. So what I'll do is just go through a little bit about the background information around the topic, and spend some time looking at the methods and results, and then discussion at the end. So the reason why I want to look at cardiovascular disease is because it is the leading cause of mortality in the world currently. And in the UK as well, it accounts for more than 25% of mortality rates within the UK. And this looks at men under the age of 75, and similar trends were present for women under the same age group as well. Interestingly, although it is the leading cause of mortality, rates have actually been decreasing over the last 30 to 40 years, which this graph shows quite nicely. And this was from the British Heart Foundation statistics website, which demonstrated this over the last 30 to 40 years. So why are mortality rates decreasing? What's associated with this decrease in mortality rates? I think first of all it's important to note actually that some studies have shown that there's a plateauing effect, that mortality rates are actually starting to slow down and even sort of not going down any further at all. And that's been shown in the USA, Australia, and also in Wales and England. It's difficult to see on the slide that I just showed you for this country. These reductions in cardiovascular mortality rates have been linked to cardiovascular risk factors. So the big 3 risk factors commonly associated with disease are smoking, blood pressure, and high cholesterol. And a recent study from 1994 to 2008 health survey data demonstrated that actually all of those 3 risk factors are actually decreasing in prevalence, but obesity and diabetes are actually increasing. So perhaps that's why there's a bit of a plateauing in terms of coronary heart disease mortalities. What we also noted was actually that there's 50 to 75%, that 50 to 75% of the decline is actually attributed to this risk factor reduction, but some of it is actually because we've got better medical treatment out there. So maybe that's clearly both risk factor trends, but also medical treatment both have a role to play in reducing mortality rates. So just to go over the cardiovascular risk factors, so unmodifiable ones are sort of age, gender, and family history, which are really difficult to control. But what we can do is target patients who have high blood pressure, high cholesterol, and smoking, because they're the big 3. And studies have shown that they are the 3 more so than the other modifiable risk factors that account for coronary heart disease. And it's been shown actually that more than 80% of patients with coronary heart disease actually have 1 or more of these modifiable risk factors. So I think it's an important topic to look at. And what we wanted to do was look at the 2 population groups in England, so the north and the south, and they're quite interesting groups. This is because the English north-south divide is a concept that's been present for several centuries, and it's been thought that the north is actually traditionally thought to be socioeconomically more deprived than the south. For whatever reason, studies have shown that again and again. A really interesting paper that came out of the BMJ last year by Hacking actually showed that all-cause mortality, so mortality rates, not specifically for cardiovascular disease, just generally, are higher if you live in the north of England. And poorer health was also present in the north of England, and this was present for several decades, for the last 4 decades. And research has shown, and articles in the news have also stated, that this divide exists, and it continues, and it's actually widened over the last 4 decades. So it's quite a topical area, really. So this article was in the BBC News website a few years ago by a professor who actually has quite an interest in this field and looking at north-south health divides. And he clearly stated that there is a clear divide, and it is becoming sharper in terms of economic differences between the north and the south, and also in terms of health. So we know that all-cause mortality rate is greater in the north, and what this slide demonstrates actually is that there is a higher incidence of coronary heart disease mortality in the north as well. So these are government office regions, so it's England split into different sort of sections based on economic and health funds that are placed in these regions. And the 5 areas in the north all have higher than national average of coronary heart disease than the areas in the south. And this was done by the British Journal of Cardiology for their annual conference. It was called the Heart Spots campaign. So we know that all-cause mortality is greater in the north of England. 13.8% of excess deaths occur in the north. And if you live in the north and you're less than 75, you're actually a 5th more likely to experience a premature death, so less than 75 years of age. And we know that this divide exists in coronary heart disease. So is it because people in the north are just socioeconomically more deprived than the south? Interestingly, studies have shown that if you take someone from the north and someone from the south and match them in terms of their income, their education, the job that they do, despite that, there is still a difference that appears to be above and beyond that in terms of mortality in the north and the south. So even if they're exactly the same, there is still this fundamental difference, which is a bit unusual. You wouldn't really expect that, perhaps. So what we wanted to do, since we know that mortality rates differ in the north and the south for coronary heart disease, is look at those cardiovascular risk factors, which we know are so closely linked to coronary heart disease, and to see whether there's a fundamental difference between the north and the south in those. And no studies at all have looked at this. There are very few studies looking at the north-south divide anyway, and nothing looking at cardiovascular risk factor trends. So those were my objectives. And what we wanted to do second to that is to look at these socioeconomic differences and account for that. So if we match the north and the south, so everyone in the north was the same as the south in terms of their socioeconomic status, is there still a fundamental difference in risk factor trends? So we use data from the Health Survey for England survey that's carried out, which is carried out by the government on an annual basis. We looked at years 2003 to 2009, and we used a population greater than 16 years of age because different questions are asked for children. Every year was a little bit different, so it's important to note, for example, there's data missing for 2007 for cholesterol. It wasn't taken on a population level for that survey for that year. Each year had a theme, so you get slightly better data for 2006, which was a cardiovascular year. And from the survey, we looked at basic demographics, as you'd expect, age, sex, and ethnicity. We then looked at several socioeconomic markers, as much as possible, really trying to account for it as closely as possible. So we looked at people owning cars, how many owned cars, how many owned a house, their education status or employment status, and what they did for a living, and also something called indices of multiple deprivation, which is essentially a score given to responders based on where they live in the UK. We also looked at several outcomes. The ones we were interested in were systolic blood pressure, cholesterol, and self-reported cigarette smoking, because, as I said, they are the main big three associated with coronary heart disease. And we also looked at BMI just to see if there was a difference too. In terms of the north-south divide, so where is the north-south divide? A lot of studies have used the government office regions that I mentioned earlier to demarcate it. So these are the 5 regions in the north and 4 regions in the south. And it's so papers have used the 7 wash line, so the area around 7, which just splits the region into 5 in the north and 4 in the south. So these are my results. So quite a large population sample, so we had 30,000 roughly for each group, the north and south, and there was no significant difference in age or in gender between the two, or indeed in ethnicity. This is what I really want to show you because I think it's quite interesting and demonstrates this socioeconomic difference between the north and the south. So we split education, if we start off with, into 3 categories based on the attainment of the individual. So if they only went to school and left school with GCSEs, they would be in the lowest education category. The next one up would be A-levels or the equivalent qualification. And third category, having been to university and got a degree from university. And quite nicely, you can see that in the north, there is a increased percentage of responders who actually are in the lower education category. So only really more people left school only and didn't really go any further with their education. The reverse trend is present in the south, with more people actually going to university and graduating from university. So you can see that swing there quite nicely from the north to the south. That same pattern is present with income category. So if you split the population of the UK into 3 income groups and then put them into how many in income group 1, so the lowest third of people in the country who earn the lowest, so that third, how many of those are in the north and how many in the south? In the lowest third, more are in the north than the south. But in the highest third of earners, more are in the south than the north. So again, you've got that very nice swing there. And same with jobs. So people who are doing semi-routine jobs, more labouring sorts of work, more of those tend to be in the north. And in the south, you've got more managerial and professional jobs. This is blue peak here for the south. So I think that shows, in each case, very nicely that there is this difference in socioeconomic status between the north and the south. So what about our outcome measures? So we looked at these measures, which I mentioned earlier. Systolic blood pressure, so interestingly, there is a significant difference between the north and the south, and the confidence intervals don't cross. So it is significant. And there's also a significant difference in smoking between the north and the south. Again, if you look at the confidence intervals there. There was no difference with cholesterol or BMI between the north and the south. So the main two, so the results so far, this is data that's only standardized for age and sex. So everyone is of the same age and of the same sex, so it's comparable data. The two significant results were differences in systolic blood pressure and smoking. If, however, we control for socioeconomic status, so if you imagine that everyone in the north is now the same as people in the south in terms of their job, their income, their education, cars that they own, everything, so all of that's controlled for, you find actually, very interestingly, this difference in smoking, this significance is lost, which indicates that smoking actually is largely related to socioeconomic status. However, this difference in systolic blood pressure remains. So even if you match everyone in the north and the south, so even taking that into account, there is still quite a big difference in systolic blood pressure between the north and the south. And then finally, we controlled furthermore for BMI and smoking. So if we took that into account as well, this difference in blood pressure remains significant. And this shows the same data graphically. So you can see there's a clear difference between the north and the south in terms of blood pressure. And when you take into markers of deprivation, that significance remains. Cholesterol, there's no real difference between the two. And there's this interesting peak in 2005, and we can't really, when we look at the data, it's unclear why this is happening, but it is controlled for. So when you take deprivation into account, this peak disappears. So it seems to be related to one of these markers of deprivation, but we can't really figure out why, actually, looking at the data. And smoking, and this is a very nice graph, because it shows there's a big difference here. And then as soon as you control for deprivation, there's no real difference between the north and the south. So it's very nicely related to deprivation. So just to summarize those results, so the trends were decreasing, actually, as other studies have shown, for all three outcomes in the north and the south together, and parallel decreases. However, there was a significant difference in blood pressure in the north and the south, and that persists when you control for other factors. The difference in smoking, significant difference in smoking prevalence exists until you control for socioeconomic status, and once you do that, that difference disappears, and there was no difference in cholesterol. Possibly with an eye of faith, there's a little bit of plateauing in blood pressure and cholesterol, but I think we need more years really to look at that. It's difficult to see with the data we've got. So smoking appears to be closely related to socioeconomic factors, and it actually has been shown to be a very large risk factor in terms of coronary heart disease, with this study looking at the impact study specifically, which was a study looking at how much of these risk factors affect reduction in mortality rates. And smoking was actually thought to have quite a big impact in mortality, accounting for about up to 50%, with blood pressure and cholesterol accounting for more like 10%. Other studies have shown slight varieties in that, but smoking has always been up there as one of the biggest risk factors. And I think more interesting from our point of view, because this has already been, some studies have shown this looking in Scotland and smoking and socioeconomic status, but this has never been shown before, which is northerners have this higher systolic blood pressure, greater than southerners, even after you control for deprivation factors. So why is this the case? It's quite difficult really to look in the literature and see, because no one's looked at it before, but people have suggested that cold stress, this idea that people in the north actually, if they are poor or live in poor housing conditions, where they're more exposed to fluctuations in cold, less well insulated in terms of their housing, and more mold present in their house, and those sort of factors can affect your blood pressure and cause fluctuations. So cold fluctuations can affect your blood pressure, and hence leading to high blood pressure in the north. And there was a study that did this in Glasgow, where they took a population of people who were living in really poor housing conditions, renovated their housing, looked at their blood pressure before and after, and saw quite a marked improvement compared to the control group, where they left them in the same housing that they were in prior to that. So that's an idea that's been thrown out. It still needs a lot more work. Another thing that we couldn't look at was life stress, which is we control for socioeconomic factors as much as we could, but actually, are there things that happen earlier on in these people's lives that set your blood pressure or cause your blood pressure to be higher at a lower age and therefore remains at that high level? We can't look at socioeconomic differences throughout time for these individuals, and that may well have an effect. And there's this idea of the Glasgow effect. So in Glasgow, even after you control for several socioeconomic factors, there remains, above and beyond all of that, a a greater likelihood of mortality and morbidity from health problems in Glasgow, and it's the Glasgow effect, and perhaps in the north, despite controlling for everything, this difference will exist. So that's an idea that's been present in Scotland and may well be applicable here. So why is all of this important? Lots of papers repeatedly state in articles in the news that the government spending cuts will hit the north the hardest because there's greater unemployment in the north, that there's a greater reliance on welfare benefits and public services, and if they are cut, then this is likely to accentuate a health divide that appears to be present. So how do we target these issues that have been raised? So blood pressure, I think the NHS health check programmes, if they work, may well pick up those people who need to have their blood pressure controlled a little bit earlier, and they maybe attenuate this difference that we see. I think it's important for general practitioners to know that this difference exists, so that GPs in the north can be aware of it and actually try and seek out those people who need blood pressure treatment. And then focusing on the socially deprived individuals, because it's very clear here that smoking is related to that. So if we can target those people, if they do smoke, then try and convince them to stop, that would reduce quite a lot of the coronary heart disease mortality, perhaps, that we see. So I think overall there were several strengths and weaknesses in the study. In terms of strengths, quite a big sample size, and it was nationally representative. I think it was quite good that it was a repeated cross-sectional survey on new individuals, so we're looking at different populations each time, so it really is representative of England over that period. And we used multiple measures to control for socioeconomic status, which I think is, again, a strength for the study. However, within the health survey itself, there's a lot of self-reporting, which could be affected by bias, and a lot of the response rates were suboptimal. A lot of data was missing. We had to cut out a number of individuals because we didn't have all of those measurements for everyone. So it made it very difficult. We lost a lot of data as a result. Some other things just to mention, and although we control for socioeconomic status as much as we could, there are so many other factors that we couldn't control for, and maybe that is why we see this difference in blood pressure. So it's difficult to say. We didn't look at wealth, for example, where people can inherit houses or inheritance and things like that. And it's just a very complex topic because all these risk factors, in the end, they do interact. So cholesterol and blood pressure, everything is likely to interact in terms of causing coronary heart disease. So now, in terms of taking this further, we want to look at males and females separately and age groups separately within the north and the south. And interesting data is actually showing, when I mentioned the plateauing, that actually there is some plateauing in the younger age groups in terms of reduction in cardiovascular risk factor trends versus the older age group. So that's something we're focusing on now. And because trends were parallel in the north and south over all of those time periods, we're actually looking at 2006 specifically now, because that was a year associated with cardiovascular disease. So I think the data will be a bit better, actually, for what we're looking at. Just over this whole process, just a little bit about what I feel that I've learned from it. I chose this because I'm interested in cardiology. I did this as an F1 at West Middlesex, and I felt that it's an area of interest of mine that I wanted to explore a bit more. So I wanted to do research looking at risk factor trends, and just to further my own understanding, but also it may be useful in my future career. And I wanted to do a quantitative study because I have done qualitative studies in the past. This is something a bit new, and I'd quite like to learn how to analyse data a bit better. So that was really why I chose something like this. The north-south divide came about because that BMJ article that came out last year was quite interesting. I'm from the north and I had a personal interest in it. I thought it would just be quite nice to have a look at risk factor trends in these two populations. But I did find it very difficult. It's quite an abstract concept. I still find papers about it quite difficult to read, particularly about sociological aspects of socioeconomic status and etc. It's very different from what I'm used to in medicine. So I've learned a lot more about that. The data was really difficult to analyse at the start. I didn't really know what I was doing with Stata. I went on a course and it helped, and I know a bit more about statistics. But I do quite like Stata now. I think it's fast. I think you can get a lot of results very quickly, and it's increased my understanding. And I think finally it's just been a great environment to work in. I've had a lot of support. Andrew's been very patient with me as my supervisor, because I have found it difficult to understand these concepts, and I think he's been a great help, and so has everyone in the department. So I'd just like to thank Andrew for being a fantastic supervisor, and Graham for overall supervising everything that I've been doing, and Jenny for helping me in GP practice as well in terms of my clinical work. And I know James isn't here, but he's helped me with teaching, with my work in the Singapore curriculum as well. So thank you, and those are my references. Does anyone have any questions?